I'm gonna go ahead and turn off the ding dong noise.
Thank you for that, Patty.
Yeah. I had it on so I would hear when people started showing up, but now there's plenty of people here. I don't need it anymore.
That is correct. Awesome. We'll go ahead and get started here in a second. I'm going to pull up the presentation.
I'm gonna go on mute so that you guys can't hear my dogs barking in the background. I will be letting people in as they arrive.
Thank you. Does everyone see the presentation?
I can see it.
Yes.
Okay, wonderful. I'll try to get my screen sorted out so I can see when people are participating. And I think we need to give it a few more minutes just in case we have some stragglers. So I'm going to go ahead and go on mute for a few minutes and we'll probably start about 10:03.
Good morning, everybody.
Morning. Okay, it is 10:03 and I don't want to waste anyone's time, so I'll go ahead and get us started. If you take a look at this agenda, it may look slightly different from the agenda that you received in the invitation. That's because we use a standard agenda for all of the topics that we need to cover in QIC over the course of the year. If you take a look at those topics, they're pretty intense. So we like to break up the content over the different quarters. So this is the accessible content that we have for today's meeting. I'm going to start with discussing the minutes from the last meeting. We'll go into the access log. We'll discuss treatment authorization requests, medication monitoring, grievances, no ABDs, chart reviews, performance improvement projects. We'll discuss the QIC policy subcommittee that was brought up in the previous meeting, and then we'll assign action items and discuss next meeting dates. Does anybody have any questions about that? Okay. One warning or just preemptive notification is that we are recording this meeting, so we are not going to be discussing any protected health information. Please, if you have anything to discuss involving protected health information, please discuss that with us offline. Okay. So the last meeting that I could find for Quality Improvement Committee was a long time ago, and that's because we lost the analyst that used to run this meeting. And I have not been able to carry the torch as well as I should have. So the last meeting that we had was July 23rd, 2023, and it was conducted it was recorded. There weren't actually any minutes taken. So I've linked the recording here. You can review that at your leisure. Does anybody have any questions about that? No. Okay, so access log statistics. We received a total of 1,500 inquiries about our services over the calendar year 2024. The blue is mental health. There's some overlap in orange involving mental health and STD requests. And then the STD requests are in green, and just the little bits of blue on the very top are mobile crisis. So you can see the majority of our inquiries are mental health related, with the next runner-up being our substance use disorder services. Does anybody have any questions about this slide? And if you look at it, just looking at it, we have influx in January. It goes down in February and March, goes all the way down in June, and then we get an uptick in July, pretty significant uptick. Does anybody have any ideas as to why that occurs? Can someone talk just so that I can make sure volume is working?
Vanessa, what I can say is I can say the increase in SUD numbers is directly correlated to going live in DMC ODS in July.
Okay, that's a beautiful thing. We did, as Amber stated, we did significantly expand our substance use disorder program by starting DMC ODS. So it's basically doubled our substance use disorder services inquiries in July, and that's really good to see. And then it kind of stayed high, and it's still pretty much staying high going into December. Never getting back down to that June 2024 level. So
Also,
go ahead.
The mobile crisis are small. We know that they're much larger than that. So why aren't those calls being captured on this slide? Because they're not using the inquiry.
The inquiries log. Yeah, this data was drawn from the inquiries log. Rob, is Rob here? Rob's the one that, yeah, he's here. Rob, can you speak to how, did we pull the crisis data from Alvin for this report, or do we just rely on the inquiries log?
Just the inquiries log.
Okay, yeah, because most crisis calls don't actually wind up as a full-on inquiry.
Yeah, that's interesting that we would even plug that in there if the crisis calls don't even because if you pulled a log for the amount of calls that come across the crisis line, you would see huge numbers.
That's true. And I think a good action item for maybe the next meeting would be to go over those calls just so we can get a sense of the comparison, because what this is really showing us is the calls that made it to our access team. So there are some crisis calls because some of our crisis calls wind up needing to go through the formal access process. But there is a huge number of crisis calls that are not being reflected here in this chart because we're only focusing on access statistics.
And Katie keeps, so that you know, because of our CCUM grant, Katie keeps track of the number of calls that actually come in on a daily basis. Like she takes log of those calls.
And a good, maybe a good indicator for our timeliness metrics, because crisis calls have to be addressed within 24 hours, so we could measure that statistics using Katie's information. So that's a good
Mhm.
action item. When I speak action items, because we're using the automatic, it's taking notes for us, so it should put that on the list of action items.
Well, and a good thing of this is anybody who was engaged in crisis who needed an appointment would be in these numbers, but there are a handful of calls that don't, that don't get appointments. So,
And I mean, I don't work in crisis, so those of you who do work in crisis, maybe you can speak to this, but I would imagine a good chunk of the calls that are crisis may already be receiving services and are just, having a break or having a circumstance that's going on. So they would not be reflected in these statistics,
that
even if you incorporated those calls.
and that is a lot of them. So you are correct. So that would be interesting to find out who are new calls and who are not.
We'll make sure to include that in either our next meeting or the next time we go over timeliness metrics. So some bad news, but we have room for growth. This was 2024, and 2024 was a pretty tough year. We took on a lot of challenges, and we've had a lot of change in our access teams and our infrastructure for access. We have a 47% compliance rate for psychiatry first request to first offered. And actually, Rob, why are we, I think on this one, we're counting 10 days of requests, but for psychiatry, we should be counting 15.
So that part I probably copied down from the regular mental health requests and forgot to change the 10 days to 15 days. It
So do
is
you have
15, it is 15 days. And the numbers reflect 15 days. I probably just forgot to change 10 to 15.
Okay, so an action
Copied the-
item would be to
Yeah, because I
review
copied the previous slide, and the previous slide in my slides were requests for services for mental health services. And then I copied the slide down and changed it to psychiatry, and I forgot to change the 10 to a 15. That's all. So the actual data is correct. It's 15, it's based on 15 days.
Okay, so it's a 47% compliance rate.
Yeah.
So an action item will be to correct the slide, and then but that we're confirming that 47% is accurate for that span of time. And I don't know, Chrissy, do you want to speak to the changes that we're implementing on the meds team to ensure that we're meeting these needs? I believe there's been a lot of movement in terms
There
of
is, we're working with CBH to bring on a couple more staff to follow up on the no shows and no calls, the cancellation of appointments, making sure schedules, following up on schedules and making sure schedules are completely full. April probably has more that she's doing, but she's in another meeting right now. But yeah, there is help out there coming just to focus on cancellations, no shows, and getting people into their services faster.
we
for
don't know
sure.
many psychiatrists we brought on recently with community behavioral health services, just if you know off the top of your head, because I know we've had a lot of new providers. Maybe
I don't know if it's not necessarily that we've brought on psychiatrists. We've brought on PAs, like MDs, and I want to say we have Dr. Yu, we have Dr. Markey. Julia, do you know? You probably see their schedules more than I do.
I mean, the doctors, the telepsychiatrists,
Yeah.
I don't deal with those. That's Kim.
Okay.
Kim
Okay.
really, I just do the referrals when they first come in and when people call in for intake appointments and screening tools and all.
That's true.
Yeah. And I schedule the intakes and refer them out to Caroline if needed.
I know
Okay.
we have a handful of new ones that have come on. I don't know necessarily that they're psychiatric doctors, but they are doctors.
I think Marty wants to speak. Go ahead, Marty.
I see new names in charts every day, and I'm like, oh, who's this? So,
Just been 4. And if we have the nurse, also it would be 5. The nurse practitioner, that is.
And nursing staff can be used to support this metric. So I anticipate seeing some really good progress here the next time we do this evaluation.
I'll have to agree with you on that, Vanessa. We're going to see, I think, a huge increase with the changes April's making and the pressure she's putting on CBH. So
the other thing to think about in this metric is the low numbers of requests. Do we feel like 17 is an accurate number of new access to psychiatry requests? Or is it possible that some requests aren't being documented? So you could have a patient who is calling in for access and they want mental health and they want medications. That would be basically 2 inquiries, one for mental health and one for psychiatry.
And with our our new FSP process that we are doing, in order for them to be engaged in services, they have to be engaged in both therapy, or to get FSP services, they have to be engaged in therapy as well as medication management. So you're going to see a huge increase because we've had a huge increase of FSP requests. So you're going to see an increase.
I just think that 17, this is for the entire calendar year. I feel like there might be some data discrepancies in terms of tracking, because our medications caseload is much higher than what's represented by 17 new requests over the course of the entire year. So just something to think about. We'll dig into this. Action item would be to dig into the metrics to figure out what's going on for data tracking and see if we can remedy that on the next.
Chrissy, Vanessa?
Yeah.
Do you know if, can we go back to that real quick? Do you know if when somebody's calling in for mental health and they want mental health services and medication services, do we know if we're doing 2 access trackings on that or just 1? Because I'm not sure when we run the report, if we label it as a request for services.
I think it would just be one access, because the process is they call in, they get assessed by Julia. Julia schedules them with Kim or whoever else does that second portion. And then they schedule them with a therapist who then does the complete assessment. And then that's where we're kind of falling off, where that person's not being referred to a doctor for medications, or and that's where that those new people with CBH is going to follow through to make sure then they get that appointment with the meds provider. So I'm thinking it's 1 access, and these are the processes they're going to go through with that 1 access.
But I also,
go ahead, Julia.
Any of my notes and in access, the inquiry, I always put what the client's seeking: therapy, or just medication, or if they were just RDHT, they're just released. I put it in my notes and in my access notes. So I do both. And I ask the client, even in the screening, I ask them also, and I also put it in the screening tool.
Okay.
And she's I'm sure she's training the front office who will be taking over these processes along with Julia. She's training them to do the same thing. So that will be.
So the problem is that the system is not able to calculate the timing if there's not a separate access inquiry entered for the psychiatry piece or for the medications request. So we need to have 2. But it doesn't need to necessarily be done at the access level, because it's done at the point where the person is referred to psychiatry.
Right.
So that would have to be done with at that therapist level. That therapist will have to do that access and that request for that access. And that's a form that's in Smart Care, right?
Correct. Yeah. It's the same.
Okay. So that's something we need to talk about with Savannah and April and see where we can fix that.
So I only do the screening tool though, to see what level of care. Then
Yeah.
I pass it along to do the intake, and they do all the consents and then their screening tool, and then they go on and either schedule them for medication or therapy, whichever one. But I only do the screening tool to see what level of care, just so you know. I don't want to
Yeah.
Okay, cool.
Yeah.
Thank you.
Okay,
You're welcome.
let's understand the process. It's just a little bit, like, it would be ideal if when Julia goes in to enter an access log inquiry, she could select that they're asking for specialty mental health and medication services, and then it automatically logs that, but it doesn't. So,
Mhm.
it's just something we have to change in our process, and then we'll get better documentation on this. Okay, so requests for non-psychiatry, from request to first offered appointment. It's compliant if it's within 10 days of request, and we're doing pretty good there. We have an 89% compliance rate. So
I have a question.
Mhm.
So from the day that I get the referral or request or call, I thought it was 5 days.
There are different timeliness metrics for different types of services, like the MCODS has a few that need to be approved more timely. If we're talking about crisis, we're talking about a more stringent time frame. And if it's RDHT, recently, yeah, so those are held to a higher standard, but I believe that's 72 hours.
Okay.
So if 5 days, I don't know where the 5 days came from. It may
I don't either.
That's the RDHT. That's the RDHT. So when we've got a client coming out of hospital, we have 5 days to get him in to see a psychiatrist.
Okay. And I am, when Lori or Jamie, or actually Lori Grog, she does the emails to the BHS and to myself. I do open inquiry for that also.
Perfect.
Yeah. And program. And then I also note it too. And then I do the timeliness also.
All right. So we're doing pretty good here. The next one is MHP so this is from the first rendered appointment. So in the past, they didn't actually measure us on this metric, but it's been a more recent, in the last couple of years, they started measuring us on the first rendered appointment to the follow-up appointment. So that's another 10-day span of time that has to be covered. And we're struggling there a little bit more than the initial appointment. And I imagine there's a bajillion reasons why that's occurring, scheduling conflicts, and because now they're set up with a clinician, it's getting that person to be able to fit into that individual schedule. So it's not just finding the nearest or most available person, it's finding when that person is available. But 70% is pretty low. I think we're looking for closer to 90. Does anybody have any questions or feedback about this metric? Okay. So DMC ODS outpatient request of first offered appointment is really good. 93% compliance rate there. That's really good. Does anybody have any questions or feedback about how this is occurring? Okay. Request for services first rendered to first offered follow-up is also compliant, very compliant at 99%. So good job, DMCODS staff. So, but moving into TARS, we have, this is from a report that Marty generated out of Kepro's system. Kepro is our third party that handles treatment authorization requests for us. We've approved payments to 21 hospitals and 279 beneficiaries for 3,500, almost 3,600 days of services for the calendar year 2024. The average day of service is almost 13. The most utilized hospitals is Aurora, Adventist Health Vallejo, BHC, Heritage Oaks, and Sutter Center for Psychiatry. Our most utilized short Doyle is the same. And it looks like the same for our Medi-Cal paid. Marty, did you have anything you want to add about this slide?
No, just a special note that there was one beneficiary at a certain hospital at the Aurora Hospital for 224 days. That kind of skews the average and the days of service.
Okay, thank you. Does anybody have any questions? Are we seeing an influx in TARS over the last calendar year?
Unfortunately, I believe so. I know I compared December's admissions to last year's December's, and it was around the same. I'm pretty sure January's will be a decrease. I did recently just compare it because out of curiosity, but unfortunately, it's been a busy one these last couple of weeks.
It has, and as a action item, if you'd like, I could present that next month.
That'd be great, Marty. Comparing it to last year's.
Yes, month by month, we could do that as well.
Yeah.
Awesome. We'll do that. Thanks, Marty. And Chrissy. So moving on to medication monitoring, we had our very, very first Omnicare review conducted in December of 2024. And so these are the results of that review. I just want to throw some context in there that this is the very first time that Omnicare has ever reviewed us. These are the results. We did pretty darn good, I think. For medication storage, we struggled in a couple of areas where we need to be moving our discontinued meds to the med cart or overstock storage. We have to fix our labels so that they're not covered or obscured and that the first and last names are present. We have to make sure that our pharmacy labels have not been altered by ourselves or by staff or by the individuals themselves. Sometimes they write on the labels, and that expired medication is not present. So our Lucerne clinic did much better than our Clear Lake clinic, but we get a lot more action in our Clear Lake clinic, so that kind of makes sense. We did really good with our first aid kits and our refrigerators. We only provide controlled for narcotic medications in our Clear Lake clinic, and we did really good there. We only have a centrally stored medication record in our Clear Lake clinic, and we did really good there. Where we really have struggled is our medication destruction practices. And I know I heard some stuff that we were looking at getting the company to come out and get rid of some of our medications that are old and expired. Do you, Julia or Chrissy, do you guys want to speak to this at all? No, okay. I imagine that there's some work that's been doing that I just haven't seen on the background is what I'm saying. I think
What was your question? Sorry, Vanessa.
What are we doing about it? So the Omnicare, I know it just occurred back in December. So like the review, I mean, they literally did the review in December. We probably got the results in January. So you haven't had a lot of time. Is there any plan for how we want to address these findings with the meds team, or are we still kind of working that out?
I'm not sure what Savannah, I'm not over medications anymore. April is. And I know her I know Savannah's working on it. So yeah.
Okay.
I can't help you there.
Okay, and I did get a note from one of our members that I am not talking loud enough, so I will try to talk louder going forward. Grievances and appeals. So this is a recap of some the total statistics for the quarterly report that we submit to DHCS. We don't have a lot of grievances and appeals. As you can see, we have like ones and twos in most of these numbers, and a total of say 10 filed for all 4 quarters in grievances, and 3 were active and 8 were to be resolved. And I'm kind of curious how that doesn't total out to 10. Is Ken, are you in?
Yes, I can add to that, Vanessa.
Please.
So that middle column, the total number of active grievances, those were typically grievances that were filed towards the end of the quarter. So they weren't resolved until the following quarter. So they carry over, unfortunately.
Okay, sounds good. Is there anything else you want to add about this, report? Any specific, trends of grievance topics that had occurred over the last year, or anything you can speak to in terms of how you've observed grievances over the course of 2024?
Most common complaints that we've received are, either customer service or quality of care. The one big change we'll see for this year for 2025 is we'll be resolving grievances within 30 days now.
Okay, wonderful. Thank you, Ken. Does anyone have any questions about this slide or this topic? Okay, moving on. For notices of adverse benefit determination, we have generated a ton over the 2024 calendar year. Ken has reported that we generated a total of 515 notices of adverse benefit determination, with the primary topic being termination, and the heavy hitters with regard to who's generating those no ABDs are our SUDS South Shore and our mental health adult South Shore. Ken, do you have anything else you might want to add about the topics, or
So we have seen an increase in NOABDs, but I think that's primarily after the increase in trainings we've had with our staff and being able to generate them. So you can see, in the earlier year that started off slow, with less than 15 to 20, but then towards the middle end of the year, that's when you see the huge increase.
Wasn't there an issue with the addresses or the letters where it wasn't going in at 1.2 one month?
I believe so. I think there was a technical issue.
Yeah, that was last year. I think around November, maybe.
yeah, I think our stopgap was to generate the OEBD, and then our reception front desk would print it out and actually white out the address and correct it when they go to mail it. We did to a process. I'm gonna mute Marty because him and I are in the same office. So if you're hearing any feedback, it's probably because either I've got my sound on and he's talking, or vice versa. But the no ABDs, we actually changed the process too back around this time period, where the front office would generate a report on a daily basis and print out all the no ABDs and mail them for us. And also save a copy to the chart. So yeah, there was definitely an issue. That issue took a couple weeks to resolve, maybe more than a month. It was a huge issue. What I think is important is we probably need to up our timely access no ABDs, because I'm seeing zeros, but yet we're not compliant. If we go back a few slides, we go back to 47% compliance rate on psychiatry. We should have no ABDs for that. And then, so if we're saying 1 out of every 2 psychiatry requests, we should have a no ABD for those. And I don't think that if we're getting 0 no ABDs one month, that means we're making 100% timeliness every month, and that's not happening. The other thing, so we got an 89% compliance rate for non-psychiatry request to first offered. So we should probably be seeing about, I want to say like, 10% of all of the actions taken, all of the access, we should see at least no ABDs for that. So some work to be done on tracking and generating no ABDs for sure. Any questions or feedback on that at all? Go ahead, Marty.
Yes, just curious, does this include the hospital denials as well? I know it says denial there, but does that include the acute hospitals?
Yes. So the ones that you supplied to me, Marty, those are included in those numbers.
Perfect, thank you.
All right, so if there are no other questions, I'll go ahead and move on. Chart reviews. So I really wanted to give you guys a better synopsis of the chart reviews, and I think I actually put this on our agenda for the next meeting because I really want to have some time to process our effectiveness in terms of how we're meeting these different topics, but I didn't have the time to prepare it for this meeting. So what I thought I would do instead, we go over the topics that Jennifer Stratton evaluates when she's conducting chart reviews, and then discuss the metrics for how many chart reviews have been completed in comparison to how many caps are being issued. So the topics reviewed are assessments, problem lists, progress notes, and other documentation, as well as specialized services and billing. She's scoring, 11 items in the assessments category, 8 items in the problem list, and so on. So you can see she's looking at a lot of different areas within the chart to identify if there's any issues with the services that we're providing. She has conducted over 2024, 294 chart reviews. And she broke down the totals here by the different teams. And we kind of aspire to have her review at least 10% of the caseload. Sometimes that doesn't, if the caseload's really small, that means the numbers are going to be really small. She provided a list of the caps, and 136 caps were issued over 2024. So that means we have a cap rate of about 47% of the chart reviews that were conducted, which, some of these caps are just informational, like, hey, you could have done this differently, in the future, please do something else. And it's just that kind of thing. And then some things are where we have to initiate a chargeback on the billing if the billing has already gone through. If, like, say the service wasn't a valid service, that kind of thing. But we do have a process in place, and it's been working. And as you can see, Jen has been extremely busy pumping out those chart reviews. And that's a good indication of really reviewing all of the work of our department and ensuring that we're providing quality services. Going forward, she is planning on expanding to our DMC ODS contractors. And, one portion of this chart review process doesn't just end at the cap or corrective action plan that is issued. It actually kind of results in a clinical office hours meeting that she conducts on a monthly basis with our stakeholders who are being capped. And she does that every month, twice a month, or actually, yeah, it's every 4 weeks, and she repeats it at 10 a.m. and 3 p.m. But we're expecting to do less chart reviews in 2025. Mind you, in 2024, we hadn't done chart reviews for quite some time. We had done them sporadically here and there while we could, but in terms of getting them done for mental health on a regular basis, we really didn't have that record to set that straight. So in 2024, we really bulldozed the chart reviews with 294. This year, she's planning on doing 10% of the caseload. So that would be 5 charts for discharge planning, 1 for corrections, and so forth. She's also planning on doing 24 total chart reviews for our substance use disorder staff internally. And then she has the numbers broken down for our DMC ODS contractors. And then she does audit our fee-for-service practitioners, as well as our Lake County Office of Education and Redwood Community Services. Any questions on that? Okay. Performance improvement projects. We are struggling with them because and I'll get into that, but we've selected for our clinical PIP for adherence. We're going to measure our adherence to antipsychotic medications for individuals with schizophrenia. And then for our non-clinical PIP, we're going to work on improving the timely access from first contact from any referral source to first offered appointment for any SED or specialty mental health services. In our network adequacy, which findings, this 33% compliance rate only applies to specialty mental health because at that time we weren't DMC-ODS, so they couldn't measure us on our substance use disorder. So that 33% compliance rate is going to go up as we're now an integrated department and we are being evaluated for network adequacy with DMC-ODS. But the goal is 80%. That's the state standard. So we really need to bump that up. And we have some timelines that we have to follow to get there. This is going to be a multi-year PIP. And we don't really get to pick, like we get to pick of the selected topics that DHCS decided on, but we don't really get to pick any, there's not a lot of flexibility with regard to that. We selected from like 3 different topics, and these were the topics that we selected from those topics. And I think we picked, for the non-clinical PIP, we picked the timeliness for access from first contact because that was the lowest compliance rate we had in that findings letter. So we submitted our PIPs topic selections to the state's new third-party consultant who's doing our external quality review this year. They're called Health Services Advisory Group, otherwise known as HSAG. And we submitted that to them on January 15th. And then in mid-July, we're supposed to be measuring our baseline, which is the calendar year of 2024. And then we submit a PIP tool to them to be evaluated for competence with steps 1 through 8 completed. Some of the challenges that we're going to have here is measuring HEDIS because it's a highly technical calculation. There's several HEDIS measures, I believe 6 total HEDIS measures that DHCS is requiring counties to measure on a regular basis. And when counties are struggling to access the data that is necessary in order the protected health information to evaluate our effectiveness on HEDIS measures. So, you know, part of the struggle is obtaining the data files needed because it's claims, but it's not just our claims, it's claims for the entire system. So if we're talking about follow-up after finally first contact to any referral source, this HEDIS measure technically is measuring how effective partnership health plan is in meeting that timeliness standard. And all of those get put together, and that's how we come up with the HEDIS standard. Right now, we're just focusing on figuring out what our performance is for HEDIS because, and the state understands that. They understand that we don't have access to, say, partnership health plans, claims data to be able to determine their timeliness or our timeliness with referrals to follow up after emergency room care. It's not like we have the ability to access hospital data metrics to be able to say whether or not we're meeting those standards, but we're working on acquiring that information. Amber meets regularly with our hospital navigators. I forget what they're called, sun navigators. And Elise and Chrissy and April are working with our stakeholders and partners in the community to boost our interoperability, which will allow us to share information, share data that would allow us to calculate these measures. So it's a struggle, and we're working on getting some support from Cal Mesa as well, because they put together an offering that they can help do some of that data crunching. In the managed care conference, they attended like 2 days ago, they admitted that it would require 20,000 lines of SQL coding to calculate a HEDIS measure. So fortunately, we're really blessed. We have someone that can do SQL coding here at the county, and we have some of the brightest minds in the bunch. So I anticipate that we're going to do the best we can to meet this requirement. But the biggest challenge is really determining our HEDIS numerator and denominator, which are required components of these PIPs. And then we can start getting creative about once we've measured how bad it is, we can start getting creative about what we're going to do about that. Does anybody have any questions, feedback, concerns? Okay. So in a previous meeting, it was mentioned that there was a QIC policy subcommittee. We wound up kind of, there was a need to discuss policy in QIC. And so we kind of separated this out for the QIC subcommittee so that we could get some work done in the background while not tying up the entire QIC meeting. We only meet quarterly, so it makes it really hard to get a lot of work done. So my question to all of you is, who should be part of this subcommittee? Who should be on the subcommittee? How often should it meet? What policies should we be focusing on as the QIC policy subcommittee? And what is the scope of this committee? What do we want it to be? Some thoughts I had on that would be we should focus on policies that involve quality, quality improvement. QIC is all about quality improvement, so we probably should focus less on compliance and more on improving quality. So anybody want to say anything or have any opinions or thoughts? Should we just dump the QIC policy subcommittee altogether and focus on policy internally? I know we struggle with policy.
Are we required to have a QIC policy subcommittee?
No, it was a recommendation from one of the members in the past.
I don't
think it may be a good idea with all the changes coming down, but there's always going to be changes, and keeping up with the policies and the changes in the policies, it would be so hard to do. Especially with our integration, I guess with integration and our integration of our contracts and.
Yeah, I think that with what you're saying, Chrissy, I mean, we should have a policy committee to just continuously review our current policies and procedures and make sure that integration and changes are included in that. And really ramp up that process instead of adding an additional policy subcommittee.
Thank you. I appreciate that. Yes, we have a plan for that. Rob has a new staff that started on Monday, and that is his primary focus. So with your permission, I'll remove this from the agenda and we'll just go from there. If it ever needs to be added back, we can always add it in some future date. And also we can always bring things in. This is not a Brown Act meeting, so we can bring in topics that, are of vital interest going forward. Thank you. Appreciate that. I always love making things simpler. But yes, there is definitely a need. We're already struggling on policy. Let's not make it more complicated than it needs to be. And by struggling, I'm saying we're having trouble keeping up with all of the changes. And so it was really critical that we got some staff to help support us in that area. So we have this as a standing topic: recommend identified program changes, assign new action items. Usually, I think I kept this in just whenever we were doing things by hand, but as we've been doing this meeting and as the artificial intelligence assistant is keeping notes, it's also keeping track of our action items. Is there any action items that we didn't already cover that you'd like to see occurring in the next QIC or upcoming QICs? Okay. You can always email me with additional thoughts. So this is my plan for the upcoming QIC meetings. There are some topics that we didn't get to cover in this session: inpatient, IMD, residential, consumer satisfaction surveys. That's a struggle because Ken, you could speak to this more than I could, but they used to have them twice a year, and now it's only once a year, and getting the results from the consumer perception surveys is incredibly slow. So, do you know when we're supposed to
Expected
get
results are supposed to be posted hopefully within the next 30 days.
30 days? Okay, so hopefully by the next QIC, we'll have data on that. We're going to talk chart reviews again because I really want to dive into the quality metrics on the results in the next review. And then we're going to go over CANS and PSC 35 and credentialing. In July, we have change of provider requests. This is going to be a really small agenda because going over the specialty mental health services implementation plan is it's a big, massive effort. So I'll carve a lot of time out for that. We'll talk about provider satisfaction surveys and the results of audits and other reviews. And then I kind of push this topic, new DHCS regulations and guidance, just so that we go over it at least once. But talking about those BHINs that are really impactful to the programs. If you look at all the BHINs that DHCS issued in 2024, we're probably talking 50 or 60 of them. So I couldn't possibly go over every single one of them, but there are some that are very, very impactful to our programs and services, change the way we're doing things from the way we did them before. So it's important to discuss those. And then October 2025 is probably going to be a little bit of a repeat of this meeting. Just the same topics to go over because we're now 6 months from this point. Does anybody have any suggestions, feedback on this? All right. Well, I thank you all so much for taking the time. We greatly appreciate it. Have a great rest of your day.
Thank you, Vanessa.
Thank you.
Bye.
Thank you.
Thank
Bye.
you.